Research has found widespread and problematic use of heroin in South Africa, better known as nyaope, sugars and whoonga. The crisis is gripping the country's most disadvantaged communities, making South Africa's heroin market one of the largest on the continent. Treatment centres find that most users in South Africa smoke the drug, though a large minority also inject it. Those who continue to use heroin also become increasingly physically dependent over time. For some heroin users, withdrawal can kick in just a few hours after their last dose. This means they need to take the drug several times a day to just cope. However, research shows that people are more successful at quitting heroin when they enroll in opioid agonist therapy programs, which provide prescribed medicines to block the withdrawal symptoms. For more on this, let's chat to a director at iHealth Clinics, Dr Nomfundo Nhlapo. Dr Nhlapo, thank you for joining us for this important conversation.
Good morning, Leanne, and thank you so much for having me, and good morning to your viewers.
I suppose we need to begin this conversation by looking at how bad the heroin abuse situation and use is in South Africa at the moment, daily.
Essentially, what we know, and there hasn't been enough research to give us specific numbers, but what we know is that the use increases by 12% annually in our country. A report that was released in 2016 by UNDOC actually featured us to have about 0.5% of the country's population between the ages of 16 to 65 were heroin users at the time. And I think that's quite underestimated, to be honest. And that ranked us at about 65th in the world in terms of heroin use. So it's quite extensive, it's under-researched, and we don't really know the true reality on the ground, basically because there's not enough of the funds to go in and do enough research for us to get proper statistics on the ground.
Absolutely, and it's almost an impossibility to find out how many people are using it on a daily basis. I mean, the amount of people in buildings, in houses, on the streets, in all of these circumstances that are using it all day, every day, it's almost impossible to tell. But I, just from listening to you, can hear that that's a big underestimation of how bad the situation is. There are many reasons, obviously, why South Africans turn to drugs, and I don't want to dwell too much on that, but obviously we're talking about joblessness, we're talking about people that just feel like they have no hope, and they turn to the streets, and that's very much so where this addiction begins.
Yes, most definitely. We find that a lot of it is a psychosocial challenge, and that's why winning the battle without the psychosocial support is not going to help much. There is medical intervention, but if it is not underpinned by psychosocial issues, that is a problem, because if we're going to get people back into normal life, for instance, we need to make sure that we reintegrate them into society and also reunify them with their families. And if we have not dealt with the psychosocial issues that were the real trigger for them to start using in the first place, then we really will not get anywhere.
So that obviously is the long-term solution, and the idea to not find so many people using it. However, we're in a situation where we have many addicts here, but there is some kind of assistance at the moment, and I think that this is really good and promising news, because what we've heard is that the government is preparing to trial a medically assisted treatment program to help these heroin users who want to quit the drug. This particular opioid is called Methodone. Help us understand, what is Methodone? How is it used? Let's start there.
Okay. And lots of myths are out there, Leanne, and thank you that we have this opportunity to just do away with a lot of those. So Methadone is really a synthetic opioid, meaning it's manufactured in a laboratory. And it is really used to assist mostly for pain, as well as to assist in drug rehabilitation. It is an opioid substitution therapy. So when you smoke heroin, the actual drug goes to your brain center, known as the brain stem. And there, what it does is that it attaches to what we call opioid receptors. So just think of it attaching into a sort of, I always say that Lego effect, right? When it attaches there, it produces euphoric reaction. And that means it depresses the function of the brain. And this is why it has that calming effect. But it also, in turn, reduces the respiratory or depresses the respiratory function and can render a person unconscious. So that's the impact of heroin. And once it wears out in the body, what then happens is that you start to suffer the withdrawals and also the cravings start. Methadone itself then goes and attaches to where heroin would have attached, but it does not have those euphoric impacts that heroin would have had. So by the time the drug arrives at those receptors, then methadone has attached. And what methadone does not give you is the withdrawals. It does not also have the euphoric effects, as I have said.
Yeah.
So as a result, when a person is on methadone, they are then unlikely to want to go and seek more heroin use, because the main reason people use heroin is to actually dampen the withdrawal effects that come when the heroin has worn out of the body. So methadone then becomes quite a great substitution therapy that can be used, effectively used. I have treated over 800 patients in the country on methadone and have seen just how great impact we have had. But it actually needs to be quite a long-term therapy.
Well, that was my question to you, because it's all well and good that it takes away the cravings for the time that you're on it. But what happens when you go off it? Because it's always about the long-term use. So everything is great as the short fix takes away those cravings, and then you off of it, and then you go back out into the streets, and then you're like, okay, now what do I do?
And that speaks to duration, and I think this is quite important. We have inpatient models in our country that would, on average, treat the patient just for the 6 to 8 week period, and from there they're on their own. We have quite well explored what we call the outpatient model, and it is highly recommended because when we look at the retention figures of patients who then do not go back to use, it's really done well. At 70% in most of the programs, that's the retention we are seeing. Whereas with short-term use of heroin, with 1 in 3 patients are likely to relapse. So what we say with the outpatient model is that you are on the treatment for a minimum of 6 months. In these 6 months, you are treated by a well-experienced substance use disorder practitioner who will up-titrate your treatment slowly and listen, and with the patient reporting back whatever side effects that they may have. So it's actually patient-dependent in terms of the peak level of the drug.
Yeah.
When it comes to the 6-month period through psychosocial support, we would then help you understand that this is not a long-term plan. And we start to down-titrate the medication with you up to a point where you're able to cope without it. And on average, by 12 months, we do see a lot of patients eager to start down-titrating the methadone and standing on their own. Most of them by then will no longer be using heroin.
Okay.
So if well administered with the practitioner, it actually works well.
Then you get better results. I'm going to throw some questions at you because we don't have too much time at all left, and I know there's a lot to get through.
Okay.
Opioid addiction. This is a major problem, and we know this. I mean, I just, every time I hear the word opioid, I think of OxyContin, and that's one of those that is an exceptionally controversial. And we saw what happened when people get addicted to this OxyContin and they need more and more and more. They start crushing it, they snort it, they smoke it, they do all of these kind of things. Unfortunately, an addict is always an addict, and that's just something that unfortunately you live with. You're a recovering alcoholic until, or a recovering addict until the day you die, when you become one. And that I know from many addicts that say this. So what about getting addicted to this now?
Well, look, it is a possibility, especially because of the duration. But like I said, it is quite important that it is administered by a well-experienced practitioner, as I've already alluded to.
Yeah.
However, we always weigh the benefits versus the harms. It is way more harmful to be addicted to heroin than to be addicted to methadone.
Yeah.
And with psychosocial support, you've correctly said it, Leanne, it is dealing with the addictive personality more than the drug itself. And that is the root of the challenge. And with that dealt with, then you decrease the likelihood of dependency on methadone.
Yeah.
But just imagine heroin addiction and the many complications, the transmission of infections that it comes with, as opposed to a drug that controls and takes your life back to normalcy. It's like being on insulin. You will have to understand that this is how your life has to be assisted on the long term.
So you're basically stopping one drug and starting another drug. What's the price tag on this? Because, I mean, not that I'm saying that this is bad, because it certainly does give hope, but as you're saying, under medical supervision, and it's very important that that is emphasized here. But what price are we talking about? Because the majority of South Africans, they can't afford this kind of treatment. Perhaps you can help us there.
I love this argument because it reminds me of where we were when we were talking about antiretrovirals. However, we have equity methadone, which we used to use, and on a price tag of 1,000 Rand per month per patient. But as we get more numbers, economies of scale have assisted us, and we have found better formulas. Yeah. Currently, we're using what we call methadone, and we are down to around a figure of 600 per month to treat a patient, because this one actually needs a smaller volume for as a daily dose for the patient.
Yeah.
So we slowly getting to a very affordable figure.
So if people are looking to assist themselves, I'm looking at the time, very quickly, where do you go and get this kind of treatment? Where are addicts able to go to find some help?
All right. The City of Johannesburg has got a free program funded by the Global Fund that extends throughout City of Johannesburg, Citibank, and Heidelberg at the moment. We have the CDC program that is in Tshwane, and then there are private practitioners like myself who are able to assist you at a private sector level.
Right. Dr. Nomfundo Nhlapo, thank you. Important conversation. Wish we had more time, but I think we've really given people the idea of what this is. She's a director at Eye Health Clinic, speaking about how methadone can turn around South Africa's drug crisis.